Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
All right. So I welcome one and all to the class tonight on fetal growth restriction. Here we have our case presentation, and Nisha has been kind enough to be the case presenter for all of us. Remember that the questions will be directed to everyone, not just her alone. So anybody who feels that they are confident enough to answer, they can just unmute and answer. So you can write it down in the chat box, but the idea is to make you guys speak. That is the idea of these pro series, okay? In case you're not able to, then I'll be telling you exactly what the answer will be, right? So let's begin. Okay, Nisha, over to you.
So this is Mrs. X, 28-year, married to Mr. Y, who's plumber by profession for 2 years, resident of Delhi. She is 10 pass, homemaker, grada, a booked case. Her LMP was on 22nd of December 2023, and her EDD is 29th of September 2024. A period of gestation is 34 weeks.
24 to 25, that ways. Huh? So let's say her this thing LMP was 24 and this is 25. So that ways will be justified. Yeah. Making
and her period of gestation is 34 weeks, 1 day, with history of regular menstrual cycle. And chief complaint is during her ANC, she was found to have a fetal growth lag.
Okay, right. So history of presenting.
History of presenting pain, abdomen, bleeding or leaking, TV. No history of increased BP, headache, swelling of legs. So
okay. This is cracking.
Eating palms and soles. No.
Your voice is cracking, beta. Yeah, your voice is a little not clear. It's breaking in between. Yeah, go on.
Just let me think.
Yeah.
No history of repeated UTI, and she's perceiving normal fetal movements.
Okay. Now here I'd like to tell you guys that when a patient comes to you with a history of growth lag, you can see the growth lag, and she's already been having scans in which there is growth lag. Remember that these are the few things you would like to ask in this patient. What all are the risk factors of fetal growth restriction, guys? I have a whole chart slide for you, which I've made, and I'll be putting it very soon in the group. But I need to ask you, can you give me a few risk factors for fetal growth restriction quickly, everyone in the chat box? What do you think are the risk factors for fetal growth restriction? Yeah, you can also write down, Nisha, if you feel that you can even tell me if you have any ideas, if you have any thought process. What are the risk factors? So you can divide it, into maternal factors, fetal factors, placental factors, isn't it? So anything that you guys are remembering?
If the mother is not having adequate weight gain during pregnancy, or if she's having any medical complications like diabetes, hypertension.
Very good. Very good.
Or if there are fetal factors like any infections or any chromosomal aneuploidies, any placental insufficiency.
All right. So you have the maternal. Let's finish off with the maternal factors. What do you think will be extremes of age, extremes of BMI? These are all high risk factors from the mother alone. Mother is a smoker, drug abuse, cocaine, alcoholic. Okay, these are all high risk factors from the mother's side. What else? Mother is short statured. Sometimes it will look as if, she's having, genetically, she's predisposed to have a smaller child. You're thinking it's a fetal growth restriction. Maybe it's just an SGA, isn't it? And then all the infections in the mother, they can cause fetal growth restriction. And which are the most notorious ones? You have CMV, parvovirus, toxoplasmosis, anemia in pregnancy will lead to that. All comorbidities like preeclampsia. GDM can have both macrosomic as well as small babies, isn't it? Small gestation. APLA usually growth restriction mostly causes IUD or abortions and all that. So yeah, maybe. APLA definitely can result in clotting of smaller microvessels, and because of that, the lesser flow. That you can say that. What else? What else is a possibility apart from all this? SLE, all these, in which you have more of coagulation disorders. Yes. definitely, because they are actually causing what? Placental insufficiency, isn't it? Then fetal factors. Fetal factors, mostly the fetus is malformed or the baby is already having some genetic defect. So all those cases in which the baby is not okay to start with. Okay, all these chromosomal abnormalities, I have a list, I'll be sharing that with you. So we are right now asking her, we know already that she is a fetal growth restricted, she's having this thing, baby's growth delay. So we are now asking her all those things which we can probably associate. So you will ask her, have you ever had bleeding in pregnancy, or you've had any infections during pregnancy, any history of preeclampsia, any history, see why she's asked generalized weakness, breathlessness, anemia, itching palms and soles, not so much, this is mostly a generalized, any recurrent infections like recurrent UTIs, okay, and since when has she been feeling this, there is a growth lag, or how the baby is doing up till now, what are the fetal movements, how the fetal movements going up. So your history has to be very elaborate, right from first trimester. Now Nisha, you'll see this and you feel there's anything positive, that you'll tell me, huh? So this is the first trimester history. Is there anything that is very important for us in the first trimester, guys? Now I want all of you to think this, that why is first trimester history very important for me?
For dating of pregnancy, we need to
Yes,
get an early
yes,
pregnancy scan.
absolutely. Very well done, Nisha. That's the most important thing, because maybe it's wrong dates. That's the first thing that should come into your mind. Growth lag means what? You've got to be very sure that we're talking about growth lag and not wrong dates. Yes or no, everyone? So our important thing in the first trimester will be that we see that she's having these wrong dates are not there. We have had at least one documentation of an ultrasound for dating in the first trimester. Another very important thing in the first trimester will be, guys, anyone, and if Nisha can answer, you can also tell me.
The method
Anything
of
else?
conception.
Method of what?
Conception, whether it was like IVF or
See, usually IVF conceived pregnancies, we know the dating very well, because we are implanting the embryos. Their growth is more thoroughly monitored than any normal pregnancy. So chance of growth problem or growth delay because of congenital or genetic problem might be there, but not because of the dating problem. So yes, here the most important is fever, any infection in the first trimester, because now then she'll have symmetrical IUGR. If there has been a first trimester insult, probably she's going to have a symmetrical IUGR or fetal growth restriction or SGA baby. Okay. Anything else? Anything in the second and third trimester? We've already spoken about it. So did she have anything positive here? No, I don't think so. She's not having any, and she's coming to us at 34 weeks, isn't it, guys? So 34 weeks. So we're discussing this as second trimester, third trimester. No positive history. All right. What about her obstetric history? Is there anything specific that we need to ask? We need to know in obstetric history.
how was her cycles? No, sorry, obstetric history.
No problem. That will come in menstrual cycle, but that's a very valid point. Very valid point, because I usually I stop you at the very beginning, isn't it? I tell you about when you're telling me LMP making her EDD so and so with regular cycles. Didn't I tell you that thing, Nisha? Have you been attending my classes before? So I'm very particular that even in your exams, when you're saying that her LMP was so and so, making her EDD so and so, considering her regular cycles. Okay, so that only and only that tells us that her whatever EDD we have made, or whatever LMP and whatever calculations we are making, are in fact telling us about a growth lag. Okay, so obstetric history, not very important. Mostly primary gravitas, it can happen because multi usually are more well aware of their current pregnancy, but menstrual history is very important. All right. Anything specific in past history which we need to talk to her for fetal growth restriction? Personal is important. Personal is very important. I'll talk in detail about personal history. But past history, anything important here?
Any history of any chronic hypertension?
Yes, because anybody who's having renal transplant, chronic renal disease, chronic hypertension is going to take those things in the pregnancy. Chronic and long-standing diabetes mellitus, uncontrolled diabetes mellitus, heart diseases, all anemia already She entered the pregnancy with anemia. She can have fetal growth restriction, isn't it? So chronic diseases are any day important, isn't it? All right. So let's go further. Personal history. Why is personal history important, guys?
Socioeconomic class, the nutritional status of the mother, if the mother is in any substance abuse.
Yes, very good, very good. All this is associated with the maternal factors are bounty. There are too many maternal factors to discuss. So one is definitely socioeconomic status, her previous history. What else, Disha? What else can we think about over here? Her addictions. In Indian scenario, they don't stand very, good, but addictions are very, very important. Alcohol, alcohol abuse or cocaine abuse, smoking, all these are important. It's a little taboo to ask all these things over here because we don't have that kind of culture. But yes, it's associated. But BD smoking, a lot of them do. Okay, even from the low socioeconomic condition, they do a lot of BD smoking. All right. So this is all these become important. Dietary history here that might be asked. You know why? Why, guys? Why do you think dietary history will be asked to you? As far as caloric requirements are concerned, protein requirements are concerned, they increase in pregnancy, isn't it? So here, whether it's being met or it's not being met, we need to know that. Yes, Namrata, thank you. Very, very active student of my class. Namrata and Pavitra doing very well, and so is Shilpa. Good. Guys, do not be scared in the class. You know, the first and foremost, most important. It's not that I'll not be taking an action against the three presenters today. It is not done. If it has been asked to you, you joined this class because of this, right? So just be bindas and come in the class. Because if you are so scared in the class, which has got only some few students, how will you do it? And I have said no to so many students who wanted to present because I've already, exhausted the limit. Now I'm taking people as listeners. So just imagine how unfortunate it is that you got an opportunity and you shied away. So do not be shy, guys. Okay. I learned it this way only. We were made to do so many presentations that finally we lost that fear of speaking in front of the crowd and in front of any examiner, and it really worked very well. Jitu, there is a girl who's trying to contact me for the same, for practical package. I'll just forward you her details. Please talk to her. No? Yes. Nisha, you can continue with the dietary history, but mostly the diet is, she's a sedentary worker.
Sedentary worker with a
okay, her calorie
vegetarian
intake is around 1,700. Yeah, please
follows a vegetarian diet with a total calorie intake of 1,760 kilocalories and has a deficit of 640 kilocalories. And the protein intake is 38 grams per day and has a deficit of around 22 grams.
And it is important definitely for us because that's also a very important factor. Maybe the baby is not getting sufficient nutrition, and that is the reason why that there could be a growth lag, might just be an SGA baby. And family history, important. The family should have been a little before this. Yeah, anything specific that you would like to think about, Nisha? Anything specific that you'd like to say? Is family history important for us? Okay. So usually family diseases. Yeah, maybe certain inherited thrombophilias, maybe certain history of Frank-Apla syndrome in the family, SLE, that you can ask. Maybe diabetes, and she doesn't know that she's diabetic or not. Maybe that can be asked. Nothing specific. Nobody's going to, say anything to you, even if you mention these things. All right. So go on with the general and systemic examination. Yes.
General examination. She is conscious, cooperative, well oriented to time, place, and person. Height is 157 centimeters. Weight is 57 kg. Her pre-pregnancy weight was 50 kg with a weight gain of 7 kgs. BMI is 20.3 kg per meter square. There is no pallor, ectocyanosis, clubbing, pedal edema, lymphadenopathy. Bilateral breast and thyroid are normal.
All right.